Today I will be discussing about clinical diagnosis of brainstem stroke and localize the lesion. To do so, I have chosen 4 headings, namely anatomy of the brainstem, blood supply of the brainstem, rule of 4, how to localize the lesion. Coming to the anatomy, you are all aware that the central nervous system has got 4 important structures: cerebrum, cerebellum, brainstem and spinal cord. Coming to the brainstem, you have 3 important parts, that's midbrain, pons and medulla. And the brainstem houses important structures like cranial nerve nuclei from 3 to 12, that is 3 oculomotor, 4 trochlear, 5 trigeminal, 6 abducens, 7th facial, 8 vestibulocochlear, 9 glossopharyngeal, 10 vagus, 11 spinal accessory and 12 is hypoglossal. And apart from nuclei, we have various tracts, descending and ascending tracts. The descending tracts are motor or pyramidal tract and sympathetic tract. And the ascending tracts are spinothalamic tract, posterior column tract, continuing as medial lemniscus beyond medulla, spinocerebellar tracts. At the level of midbrain, apart from 3rd and 4th cranial nerve, we have Edinger-Westphal nucleus, red nucleus, substantia nigra and also interconnecting structure like medial longitudinal fasciculus connecting 3 and 4 6th nerve controlling the eye movements, and also substantia nigra controls the movement of the body. Edinger-Westphal nucleus is involved in pupillary reflex and accommodation. At the level of pons, apart from cranial nerve nuclei 5, 6, 7 and 8, we have locus coeruleus and pontine nuclei. The locus coeruleus is connected to reticular activating system. The reticular activating system or the tract is connected to all the ascending and descending tracts and also the pathways, the visual pathway, auditory pathway and vestibular pathway, and thereby controlling the consciousness, movement, sleep-wake rhythm, blood pressure, respiratory rate and heart rate. At the level of medulla, apart from 9, 10, 11 and 12 cranial nerve, we have gracilis nuclei, cuneatus nucleus, which is the posterior column nuclei. See the blood supply of the brainstem. The midbrain receives the supply from the posterior cerebellar artery and anterior choroidal artery. Pons is supplied with superior cerebellar artery, anterior inferior cerebellar artery, as well as perforating branches from the basilar and pontine arteries. The medulla receives the blood supply from the anteriorly from the anterior spinal artery and vestibular artery, and laterally it is supplied by posterior inferior cerebellar artery. What is rule of 4? Peter Gase has devised a easy clinical tool or rules which will help us to diagnose effectively. Rule number 1. Structures starting with M, that is median structures, namely motor pathway or motor tract, medial lemniscus, medial longitudinal fasciculus and motor nuclei. That is 3, 4, 6 and 12. Rule number 2. The structure starting with S, that is at the side or laterally placed structures are the certain cranial nerve nuclei 5, 7, 8, 9, 10 and 11, as well as the tract starting with S, that is spinothalamic tract, spinocerebellar tract, sympathetic tract. Rule number 3. There are 4 cranial nerves above the level of pons. There is 2 at the midbrain and 2 above the midbrain. So the above the midbrain, the olfactory optic, and at the level of midbrain, you have 3rd and 4th cranial nerve nuclei. And at the level of pons, we have 4 cranial nerve nuclei, that is 5, 6, 7 and 8. And there are 4 cranial nuclei below the level of pons, that is at the level of medulla, you have 9, 10, 11 and 12. Rule number 4. The motor nuclei that are in the midline divide equally into 12 except 1 and 2. Let's see the pathophysiology of the brainstem stroke. See the midbrain, the feeding artery, if it is blocked due to embolism, thrombosis, or hemorrhage. See the third nerve is involved, the Edinger-Westphal nucleus is involved, trochlear is affected, nucleus may be also affected. The pyramidal tract, sympathetic, ML, and medial longitudinal fascicles are involved. So the pons is affected due to the artery concerned. Artery is blocked. The trigeminal is affected. So also the abducens, the facial, the vestibular nucleus, the spinothalamic tract, ML, and pyramidal are also affected. So if you come to the medulla, the posterior inferior cerebellar artery or anterior spinal artery are involved. Nucleus ambiguous. This is a glossopharyngeal nucleus is affected, vagus is affected, spinal accessory is affected. So also the nucleus hypoglossal 12th nucleus. And also other tracts like spinocerebellar, spinothalamic, etc. are also affected. Now we'll come to the localization part. Suppose if you divide midbrain, pons, and medulla into medial and lateral half, you get 6 zones. Now, the midbrain, if it's the medial portion is affected, and see the M structures are involved. That is third, fourth motor nuclei, and MLF, motor tract, and medial lemniscus may be involved. So clinically, you can see the contralateral hemiplegia. The patient is unable to move the right upper and lower limb. And also the loss of proprioception, the vibration and position sense is lost on the opposite side. On the same side, you see the down and out movement and drooping of the eyelids is suggestive of palsy, and there is a normal movement of the other eyeball. And there can be a nystagmus, that is downward nystagmus, which is very much suggestive of the midbrain. And if you see the involvement of the S, that is lateral side of the midbrain, you see the ataxia because of spinocerebellar tract involvement and the loss of touch and pain sensation on the other side. And there can be Harness syndrome on the same side, this mild drooping of the eyelid, loss of pupillary reflex on the same side, and retained pupillary reflex on the right side. See the culprit artery being posterior cerebellar artery mainly, and you can recall that anterior and superior cerebellar artery may be involved. And the described syndromes named after Weber is characterized by ipsilateral cranial nerve third palsy and contralateral hemiplegia, including the lower face. There is a median midbrain involvement, culprit arteries, PCA, and midbrain lateral portion if it is involved. The Benedict syndrome is described by ipsilateral cranial nerve third palsy and contralateral involuntary movements, that's intention tremor, hemichoria, hemiathetosis, because it's due to the involvement of the red nucleus. Nathanael syndrome is characterized by ipsilateral cranial nerve third palsy and contralateral dysmetria and contralateral limb ataxia because of superior cerebellar peduncle involvement. Now, if you come to the pontine lesions, the medial portion, if it's involved, you see the contralateral hemiplegia. For example, if the left side is affected, you see the right hemiplegia and the right side loss of proprioception. And you also see the abducens palsy on the left eye. And there can be internuclear ophthalmoplegia. The culprit arteries, the perforating branches of the basilar artery. The common syndrome being described is the Millett-Gubler syndrome. There's a unilateral facial and abduction palsy with contralateral weakness of the arm. And if you come to the lateral side of the Pontin lesions, you see there can be apraxia on the contralateral side and also loss of touch and pain sensation on the contralateral side. There can be a masseter weakness on the same side, and the seventh nerve involvement may be demonstrable. It can be lower motor neuron type. See, the upper half and lower half of the face is affected on the same side. And sometimes, and on the tuning fork test, you may be able to demonstrate the hearing loss or vestibular involvement on the same side. So the common syndrome being described is four-wheel syndrome, characterized by ipsilateral cranial 6th and 7th palsy with or without contralateral hemiplegia. And the culprit artery is anterior inferior cerebellar artery. Coming to the medulla, if the middle portion of the medulla is involved, you see the contralateral hemiplegia, contralateral loss of proprioception, and 12th nerve palsy, that is hypoglossal involvement on the same side. And the popular syndrome described is Dejerin syndrome. There is ipsilateral tongue weakness and contralateral hemiparesis and contralateral loss of proprioception and vibrations, which we have seen just now. The culprit artery is anterior-spinal artery, and the lateral portion of the medulla, if it is involved, you see the intention tremor because of the spinocerebellar tract involvement and loss of touch and pain sensations on the contralateral side. And the 9th and 10th nerve can be involved because the lap is not moving on an examination, touching the posterior pharyngeal wall, and there can be weakness of the sternocleidomastoid and trapezius due to spinal accessory involvement. And there can be nystagmus, rotatory or sometimes upbeat nystagmus. And the popular syndrome described is the Wallenberg syndrome. In fact, this is the commonest affected area, especially the lateral side. It is described by ipsilateral facial and contralateral hyperalgesia and hyperthermosthesia, and ipsilateral palatal weakness, dysphagia, dysarthria, nystagmus, vertigo, nausea, vomiting, and ipsilateral oculosympathetic defect, that's Harness syndrome, and skew deviation and singulitis because of lateral medullary involvement. The culprit artery is again posterior inferior cerebellar artery. To conclude, a thorough clinical examination is mandatory, and the understanding of the anatomy and blood supply of the brainstem is essential, and the application of rule of 4 is very, very useful. Localization. Also, the bedside clinical diagnosis is still relevant, especially in the resource-limited settings. Thank you. If you like this educational channel, kindly subscribe.